Hello, everyone, and welcome to the Ultrasound Podcast. I'm your host, Jailyn Avila, and today we have an incredible guest joining us, Dr. Sophia Fornbacher. Sophia is a junior ultrasound faculty and assistant professor at Riverside Community Hospital, which is affiliated with UCR, University of California in Riverside. She recently completed her ultrasound fellowship, and we are thrilled to have her share her experiences and expertise with us today. In this episode, we are going to talk about two amazing cases where ultrasound helped dramatically change management and likely save their lives. Check it out. Hello, my name is Jailyn Avila of the Ultrasound Podcast, and I have with me a special guest, Sophia Fornbacher, who I met 3-ish years ago, I want to say, right? 3-ish years ago.
Just about.
She's a phenomenal individual. So excited that we have been able to teach workshops and interact a bunch because regionally we're in a pretty similar location. Sophia is junior ultrasound faculty and assistant professor at Riverside Community Hospital, which is academically affiliated with UCR. She just finished her fellowship, which welcome to being a fellowship trained physician. Sophia, welcome.
Thank you so much. Honestly, you have been such a big inspiration, and I'm so honored to be here. I'm very excited.
You're so sweet. Thank you. We are going to talk about a couple of cases.
Let's do it.
All right, Sophia, for our first case, tell me about this ultrasound and the case behind it.
Okay, so this ultrasound is honestly a pretty great case because I think without this ultrasound, we could have made things a lot worse. So this patient was, roughly 70-year-old female, transfer patient concerned for new STEMI, new left bundle branch block on EKG at an outside facility, transfer to us because we're a STEMI center. They were endorsing chest pain, abdominal pain, nauseous, vomiting. I called cardiology. We had no labs back from the outside facility, so I really had no idea what was going on. When I called the outside facility, they're like, hey, tropes are 4,000. So I spoke with our cardiologist. They're like, I don't think this is STEMI. I'm going to come to bedside. So we do this ultrasound at bedside. The patient's pressure, by the way, en route was fine, 110 systolic, but at bedside, it was now like 80/50. And so I was, getting a little stressed. So we used our ultrasound and took a look at the EF, and the cardiologist was like, this is a horrible EF. This looks like heart failure. I was like, yeah, I know, this is kind of crazy. We looked at the IVC, as you can see there, it's very plump. There's like no respiratory variation. And with a pressure of like 70/40, I mean, my instinct is always to, start with fluids. But in this case, I think it would have made that patient's case a lot worse.
Absolutely. I mean, the differential here is broad, right? I mean, it could definitely be an NSTEMI, right? It could be sepsis. It could be heart failure, it could be a PE. There's so many things. And it sounds like ultrasound was pretty instrumental in helping you really tailor the management and not cause iatrogenic harm with this patient. I'm going to take a brief pause here just to let you know that all of our content is on the coreultrasound.com website. That is Ultrasound Podcast, 5 Minutes Sono, Ultrasound of the Week, Clip Bank, and we also have our courses page where we have the Core Ultrasound Fundamentals and Core Ultrasound Question Bank, where you have 3,200 questions with feedback, including narrated videos explaining the question. Check it out, and back to your video.
Yes, absolutely. So other things kind of going on with this clinical picture to give you guys a little more information was that, the outside facility already gave aspirin. The chest x-ray showed possible pulmonary edema versus infiltrates. White blood cell count was like 19,000. So sepsis was on the differential. He was being treated for pneumonia, already got some ceftriaxone and azithromycin en route. So I was already worried about sepsis. I was now worried a little more about like heart failure, cardiogenic shock. Our repeat troponin went up to 13,000. So ACS is like still on the table. Additionally, his glucose at the outside facility was around 400. And when I got my repeat labs, the glucose was around 700 and the anion gap was elevated to like 19. So on top of all of this, this patient was also like in DKA. So there were several things.
As we say.
Exactly. Exactly. There are several things in this case that really pushed for fluids, right? The DKA, the sepsis, all of these things, your first instinct when you hear those things or you're looking at those labs and you're thinking about that is, I need to get fluids. But in this case, as soon as you put the probe on, this gentleman had horrible EF, plump IVC. Fluids would have totally made this guy crash, and we would have had a really tough airway to manage. So I think this is a great case to demonstrate, the more data points you can get, the better you can manage your patient. And there can definitely be multiple causes of the patient's distress. And you definitely want to make sure that you see the real-time physiology so that you can do the next best step. And I think ultrasound is one of the key tools that we can use to help us make those decisions.
Totally agree. All right. Why don't you tell us a little background about your second case?
Oh, my second case. So this one is quite a journey. This case is about cardiac tamponade. But what we're going to start with is kind of how things first initiated. So I'm on shift, resident comes and grabs me, and she's like, "Hey, this guy in the ambulance bay, I think we need to activate a code stroke." And I'm like, "Okay, she's one of my senior residents. We're cool." I was like, "Yeah, girl, let me go see them." So I see the guy and altered. The story that I get is, 50-something-year-old gentleman was in the kitchen, had a few beers that day. They were celebrating. Suddenly they collapsed, had a seizure, went away after about a minute, generalized tonic-clonic. I had no past medical. I didn't know diabetes, blood pressure. I don't know. Didn't know if they had a seizure disorder, but the person was still altered. They had kind of a left-sided gaze. They weren't really moving the left side of their body. And so I was like, you know what? I don't think this is a code stroke. I'm thinking maybe a little more brain bleed, altered mental status workup, but we're meeting the criteria. We're in the timeline. Let's get this patient over to CT. Initially, the patient was managing his airway just fine. So I was like, go to the CAT scanner. Let's see if there's a bleed. They get the non-con, and our neuro team sees old strokes. So we're really kind of thinking about stroke as the primary etiology, but they're too altered to continue the rest of the scans. So they bring them back for intubation. We ultimately get the airway. The patient appears more diaphoretic afterwards, and we're having a hard time getting pressures. We place an A-line, and we see that the patient's now hypotensive, 80/30. So first thing I do is I grab the ultrasound because that's what I do when I get stressed.
Of course, as do we all.
Let's get the probe. And so I started with this subxiphoid view, and as you can see,
that is quite impressive.
Yes. So initial blood pressures for this patient were systolic 180s. Now they're down to, they're hypotensive systolic of 80. And this was the first view we got. So immediately I was very stressed. And you can see that obviously the right ventricle there is collapsing. So this patient is demonstrating tamponade physiology.
That's the right heart right there. And this is a subcostal or subxiphoid view, which is traditionally the one that we teach is best for effusions. And it's easy to get, especially if someone's on pads and stuff. So what'd you do next?
Well, I started sweating. But, I talked to my resident. We try to get cardiology on the phone.
Mm-hmm.
Going to see if, we have fellows. They usually come down and throw in drains. But the patient's pressures continue to drop. We were going down systolic 70s and 60s. I grabbed my resident. I was like, we have to place the drain now. So the next thing that we did was place our pericardial drain.
And we're doing a lot better. And we can actually see the drain right there, right where it's supposed to be. It's not going into the right ventricle. It is just, just kind of resting. We'll say resting on that epicardial fat pad there, right? And presumably, how did the patient do? Patient do a little better?
Oh, yeah. Blood pressures got way better. The patient was much more stable, and everyone could take a deep breath.
I love that. And here it looks like, it looks a lot better, right? It looks significantly better than it was before. Is this, I think this is still a subcostal, right? Yeah, because there's the liver right there.
Yeah.
Still a subcostal view. Just the probe going the other way just because of the, curvilinear transducer with the abdominal setting. So the probe mark on the cardiac settings over on this side. So that's great. So I think that this one to me is, both the cases are important, but to me, this one is almost more classic as to why it's so helpful to use that ultrasound, because the management here was it could have literally been the opposite and the worst thing to do, right? Because if you're seeing old strokes, you have stroke-like symptoms, you have a seizure, you could push TPA, right? Or TNK, whatever you use at your facility. And that would be the absolute opposite thing to do. It actually would be a harmful thing to do. Although, patients get it and it's fine. I had a case a while ago, and it was a patient that was syncope. And I found we had to code him a little bit. And I found a DVT on the femoral area when we were coding, which that's something that I do. Because if you see that, if you look at the literature, it actually is like a positive likelihood ratio of like 20 for a PE as the cause of the problem if you see a DVT in their coding. And also I saw right heart strain, and the patient, we had essentially started chest compressions in the ER. So the likelihood of right heart enlargement from like venous, like not good cardiac output, like backflow was pretty low. And then that patient, turns out they had cancer, and they had a pancreatic stent that had eroded into the lung and caused a tension hydrothorax or hemothorax. And that's why they syncopized. And we gave the patient TNK. So sometimes, like, even with the data, you do your best. And I think as long as we reason through it and do what we can, especially with that ultrasound, most of the time it helps. Like in your case. I mean, this case is amazing. And to me, it's like kind of bread and butter as to why we should be using ultrasound, especially on our critically ill patients, that they're doing something that we don't expect, right? I think those are the best patients to do this in.
I agree completely. Anytime I'm worried about vital signs, the first thing I look for is the ultrasound to just guide my next step. And with this case, as soon as I saw that pericardial effusion, the first thing I thought was, this is a type A dissection. And when we got the CT angios, that's exactly what it was.
Amazing. Good call. Now, this is a short podcast. I wanted to ask you if you had any shouts out. I know you have a lecture coming up at California ASAP in September. I know that you have an ultrasound fellowship where you're at. Do you want to talk about those and or talk about any other projects that you're into right now?
Yeah, I'd love to. So I just finished my ultrasound fellowship at Riverside Community Hospital, and I am truly grateful to the ultrasound division there. They have really mentored me through a lot of tough cases this year. They've really helped me kind of, through some amazing projects that really got me the opportunity to speak at things like Cal ASAP. So Dr. Eva Tovar, Dr. Siri Chamarty, Dr. Julia Glavinik as well. And we recently brought on Ron Goubert. So
Yay.
I'm looking forward to working with this group and having new projects. So we are young, we are excited, and we're here. If anyone's interested in fellowship, we'd be happy to talk to you. And if anyone's coming out to Cal ASAP, I will be speaking on using ultrasound guidance to identify the cricothyroid membrane for patients who are currently stable, but you're a little worried about that airway.
I love that. Brilliant. All right. Well, thanks so much for stopping by virtually, and I can't wait to see you in person. Our first case involved an elderly female with suspected STEMI due to a new left bundle branch block. Dr. Fornbacher shared how ultrasound played a pivotal role in accurately diagnosing this patient's condition. They diagnosed severe heart failure instead of a STEMI equivalent with DKA. Through careful ultrasound examination, they avoided potential harmful treatment, a bunch of fluids, demonstrating the power of real-time ultrasound assessment. In this case, the differential diagnosis was broad, including STEMI, sepsis, heart failure, pulmonary embolism. Ultrasound helped tailor the management and avoid iatrogenic harm, which is precisely why it's such a valuable tool in emergency medicine and any kind of acute care scenario. Our second case was a case of a tamponade from a thoracic aortic dissection. As Sophia recounts, the patient presented with altered mental status and hypotension, plus or minus stroke symptoms. Using ultrasound, she swiftly identified the presence of a significant pericardial effusion causing tamponade, which led to the crucial decision to place a pericardial drain emergently and at the bedside, ultimately saving this patient's life. These cases underscore the critical role in ultrasound in assessing and managing complex patient scenarios, From aiding to the differential diagnosis to guiding intervention, ultrasound proves its worth in the critical care and acute care settings, especially when rapid decisions can drastically impact patient outcomes. We hope you found these insights from Dr. Sophia Fornbacher invaluable. I know I did. Her expertise and dedication to advancing ultrasound practices serve as a reminder to the importance of continuous learning and innovation in emergency medicine. Thank you for joining us today, and we look forward to bringing you more impactful discussions in upcoming episodes. I hope to hear from you soon, and happy scanning.